So thank you so much for being here tonight. I am Dr. Rod Story. I'm a local family physician. So I'm going to be talking about direct primary care. I am a direct primary care physician. I'm an owner of a practice in primary care, direct primary care, called DPC, and you'll see that initials used a lot here. It's really amazing to see, because we started off as just a hyper-local desire to practice good medicine for the people that we know in our community, and to come and see that it's actually a growing way that a lot of family physicians and others are engaging in the marketplace and networking with others in the free market to kind of create a whole different alternate medical society, which we're really thankful for. So I'm going to be talking about specifically working with employers and employees, because we think DPC is a great way for employers to care well for their employees, to really make the health care that they pay for actually more cost-effective, better, and more accessible for their employees. So we're going to talk about budget friendliness. How many of you grew up in a rural town? Do you mind showing me hands? I did. I grew up in a town of about 5,000 in northeastern Wisconsin, in Peshtigo. So if my friend is here, he can probably point out where that's at. Great little town to grow up in. I had a family doc who knew me well. In fact, I went back in college, walked in the door. He knew my name just walking in the door. It was crazy. I hope you had that experience growing up, because that's kind of a faded experience. There isn't a lot of people who in their healthcare walk or their experience with their family doctor could ever say that that's the case, mostly because networks come and go. The market has become very mobile as people are constantly moving on, and doctors have been very much a part of that experience. But back in the day, you knew your family doc, and he knew you. And he was there, and he actually probably did an expanded care all the way from delivering you to caring for your grandpa. I had one experience where I had a funny scar that developed after knee surgery, and guess what? It's a genetic thing. And the guy said, "Oh, hey, is that your grandma?" Because she had the same scar. Crazy how a small town doctor could know that thing. But this is, unfortunately, the experience. We have a really great DMV here, so nobody ever gets a DMV joke. But if you were in a Seattle area where you had to take a number, most hospital experiences, most clinic experiences, because they've been bought by hospitals. Almost everybody in our area, particularly, we're down to 2 independent clinics, and except for the DPCs, which we have several here, have been bought up. And the model is a very impersonal experience, one where you kind of park yourself and you wait hours, and you hope that you're going to get in. You're wondering sometimes why it's taking so long. It's just as painful for the doctors that are working there. Trust me, because I used to work in that kind of circumstance. And for the staff, I mean, it's just really an unpleasant experience. What a lousy thing. Really want to talk about how direct primary care can be remarkably different, not just in some of the things that you've been hearing about the painfulness of cost and lack of transparency, and the challenges of navigating a really what seems like complex medical environment for getting what you need, but really making care better and kinder. We use a word in our practice, cheerful. When's the last time you heard that in medicine? Something we strive for. This kind of thing. Doctors who actually know patients. And one of the greatest experiences about direct primary care is when you remove the red tape of a large administrative burden, when you simplify the financial model, which is an agreement on a monthly basis for care that we give for a membership in return. It gets very, very simple. And our staff ratios and the amount of time that our physicians have to spend documenting or chasing down prior authorizations or trying to convince insurance to give reduces almost to nothing. We instead spend that time with the people that we're caring for, which turns out to be a really great way to practice medicine. Not just in doing good care, but also satisfaction. And if you know medicine, you know that burnout is a real problem. People are leaving medicine in droves. We're hoping that we're seeing a reversal of that as people are joining direct primary care. So in our practice, and you may have heard this, he was mentioning earlier that the average family physician cares for about 2 to 3, sometimes 4,000 people in their patient panel. Because of the financial model, of just directness without a whole lot of fluff, we have about 500 to 700 patients per physician. That's about the same size as a small town. That's about the number of community people that you can interact with, know over time, be known by them as well, develop a comfort with, and spend some time with them. What's remarkable too is the cost falls dramatically. So I'll share with you some of our numbers. First off, to go back a second, our membership is less than $100 a month. We add on kids for $35 a month. That turns out to be about $1,000 a year for our patients, for about a family of four, about $2,500. That's not cheap, but that money is all local. It stays local. It's 95% of what we receive as membership goes immediately to our staff, to our physicians. It stays right here. It's not going off to some insurance plan. It's not going elsewhere. What's cool to us is that it changes the way that we market ourselves as too. Because what we're basically asking in membership is for our professional, to cover our professional care, our time. And once you do that, everything else doesn't have to have markups, doesn't have to be sold, and you don't have to try and recover costs from this or that or markup. You can just actually offer it as a blessing to people. So for us, over time, and we've been in practice 6 years, we offer as many things as we can at cost, including laboratory testing. So we actually have a lot of patients who find their way to us just because it's hard to find a doctor. And they're like, well, $100 a month, I'd be glad to see that go to you. And great, then I'll know I have a good doctor I can get in that same day. And then they bring their insurance to us and they say, great, can I use you to order insurance labs? And I say, well, sure. But you want to see what those would cost if I ran that through on our cash price? Sure, they say. You know what it turns out to be? 90% less. So most of the panels that we run, and we run extensive panels for people sometimes. Most of our labs are $30 to $50 for a pretty large size panel of labs. That when we look at the insurance rate for that is in the $300 to $500 range. That's crazy to us. But what we find when we kind of make it simple, because what we do in our practice is we pay cash on the barrel. We pay every month to our vendor, and they give us great prices because they're like, you always pay. Not 90 days out, not 180 days out, not a denial in the system, which is built in, but we pay that month and we get great prices. So we do the same with x-rays, and our x-rays are $60 to $80 for an x-ray, includes the reading for it. We get to see it that same day. We do the same thing with meds. We actually have to charge a few pennies just to cover the labels we put on, because the meds turn out to be $1 or $2 for 90 days worth. That's the reality of healthcare. And you've been told that it's very expensive out there, so you need an insurance plan to help you. Because they're going to negotiate, or they're going to go to bat for you, or they're going to get you the best price. That's just hogwash. We see it all the time, where we sit down with people and we look at, what did you get billed for this? I had a little lady come to me and she was like, oh, I'm so glad I have that extra Medicare Advantage, this and that. And she showed me a thing through a major chain pharmacy. And she was like, oh, I'm so glad, because look, it would have been $300 for this med for the 30 days. But thankfully, because my copay, I only had to pay $10. Well, I had just run that price. It's a generic med out of India, $2 for 90 days through us. But the federal government was getting billed $300 a month. Man, we see that all the time and it scares us, but we love the other side, which is just being able to show people, man, you can actually, for most of your healthcare, for most of what you need doctors for, just pay it out of your pocket. And we can show you, and we'll walk you through on that. We do that with imaging, and you heard, because we're not in anybody's network, we get to work in some fun circles and develop opportunities for echocardiograms and for MRIs. And you might have to drive a little bit, but if you could pay $400 for your MRI versus $4,000 here in town, you might make a shopping trip to Spokane. And here's the other thing. Family doctors have by and large, found it really challenging just because of the workload, and it's mostly paperwork, and I came from that kind of practice. Found it really difficult to be there after hours. We love that. That's our best moment. We love shining for that because those little life events, which turn out to be so expensive once 5 o'clock hits and you have to go to the emergency room, and we can get on our phone, get a text, see you 15 minutes later, throw some stitches in, send you home happy, and nobody's worse for the wear. Those are sweet moments. And what a great way to practice medicine. And we forget that, and what a great thing that our physicians have had a chance to return to that joy. I've been a family physician for 20 years. University of Washington, finished up at La Crosse Mayo Clinic for my family medicine residency. Afterwards, went back to my same hometown, Peshtigo, Wisconsin, where I started to practice. So I was the only family doctor in that little town of 6,000. Oh, I loved it. It was great practice, but it was challenging because God gave me this, a large family. And it was really hard to be a physician of a town of 6,000 because I had most of those patients in my practice. And be home to love this family. And my wife let me know that that wasn't the long-term plan for us. So we actually moved to the Northwest in 2008 because I burnt out. Because that insurance model, and this is long before all the current hoopla and craziness has hit, really did us in a hard way. And I wasn't necessarily ready to leave medicine, but I was pretty discouraged for being just 4 years out and certain that I was going to be that family doctor that all of us have in our memory. So I came here and I worked for a hospital here, working shift work, emergency room. So that's me back in the day. Not ready for all the red tape that I ran into. Put through the sausage grinder, turned into a bratwurst, I think. Worked for a local hospital and loved the work. Great to take care of sick people, great to leave at the end of the day. Really a little bit oblivious to the economics and the politics of hospital because I was just glad to keep my head down. But didn't have that opportunity for too long because in 2007, 2017, hospital kind of pulled something out from underneath me. Found out that they were going to begin doing transgender surgery through our hospital. And because my job was to support the surgeons, I was going to be required to participate in that, prepare those patients, care for them. And I was like, whoa, small town hospital, really? Me? I just want to do good medicine. That led to realizing, okay, this is not going to work. You guys are dedicated to go this direction, and I need to go a different direction. But that was a wake up because what are you going to do? Well, this is what we did. A number of people in our community said, why don't you start a family medicine clinic? There's a doctor here and he's retiring, and maybe you can take over for him. But man, I was so scared because we just left one of those meat grinder positions just a little less than 10 years before. And I knew from talking to my family medicine colleagues that it had gotten a lot worse out there. Like, I can't do that. We ran into a Freemarketmedicalassociation people. Never seen such happy doctors. What in the world? Grumpy doctors. Like if you've spent time with doctors, it's just like, oh, happy doctors, sharing joyfully with each other, encouraging one another, saying, yeah, I found this thing. Oh, you should do this thing. Oh, this is starting over here. Wonderful ingenuity, wonderful joy, wonderful success. I mean, that actually all goes together, right? So for us, that's what we ended up with, was starting a little practice in a 2-bedroom cottage that we turned into a little office. And if you drive downtown, actually, 1 street over that way, 2 streets that way, you'll see our first practice that we started. It's now some friends of ours bought it for a real estate agency. And that's how we started, just a little. And that's where most DPCs start. In fact, there's 2 of my DPC colleagues are here, and they're starting just like I did in that same kind of unique homespun, caring for people in a very individualized and very present way. This is where we are today, 6 years later. We've grown to about 3,000, a little over 3,000 patients that we care for. Still keep that same model of 600 to 700 patients per physician. We have another nurse practitioner joining us this fall. We're going to be recruiting for another provider this next year, just as the things have gently grown and we've been consistently able to just build and give care that is really all about time. That's what we found is the missing element in medicine, is just being able to give time, because we have the skills and we have a deep abiding interest, but we've been held back in most of the medical model from being able to actually just be present, to hear our patients, to talk to them, to examine them thoroughly, to educate, and then to explain why we're doing, rather than just, here, take this, prescription, go, specialist, go. We'll be able to actually say, hey, I think I'm a well-trained doctor. I think we could do that. Let's work on a couple of these things, and I'll see you back next week or a couple of weeks from now, and we'll work this out. And then if we need to get a specialist, hey, I got a friend. We'll call him on the phone. We just we're able to grow into this property, and we're excited about it. It lets us add some services and be able to let our staff work in a more efficient and pleasant way. It's an old state building, and the State Department of Health and Welfare is downsizing, and we're upsizing. Kind of a cool thing. So what's the secret sauce? It's not that secret. Good medicine takes time. We say one of our byways is great care takes time. It really does. I mean, it's just simple like that. Like everything else, right? Good bread takes time. It's not the one that you pop out of the Betty Crocker and throw it on the grill. I mean, that's good, but it's not great. The great stuff takes a little more time. Let's talk a little bit about the climate that employers find themselves in. So we have a little over 3,000 patients we care for. Of that represents 41 businesses. That's been our most recent growth over the last 2 years. And that surprised us, because we really were like, family to family, individual to individual, friends and family telling each other, hey, I like where I'm getting care. I like this doctor and he's doing good by me. And it's cost effective and it fits my health share. What do you know? But what we're hearing from our friends who are in industry is that it's getting ridiculous. I mean, and I left back in the early stage. What they're paying for health coverage is very, very expensive. $24,000 for most families. That's a far cry from the $2,400 that we do. Now, we're not insurance, and we would encourage people to partner us with other things. But even if you're a self-funded, or if you encourage people to go get a health share and you give them the funds to do that, it's a tenth of what you're seeing there. And this is the real challenge, is that health coverage turns out to be not coverage at all. You got this crazy deductible that most families are paying before they even get to use their insurance. It's a crazy thing. I think $5,000 to $7,000. This is a couple years old. This is not a conservative think tank. KFF is a very liberal leaning, but very. They publish a lot of data in the health field, and they're plain about it. This is a real problem that has been growing well beyond workers' earnings, and if you factor in inflation over the last couple of years, it's crazy. Yeah, overall inflation, you like that? It's kind of tinkling along until 2020. But what that really means is people have this coverage they can't even use, and they're disincentivized to use it. Insurance companies know that, and they sell these products with the hope that people don't use them because it gets expensive if they use it. But that's okay, because honestly, that's not what insurance is for. Insurance is really a poor fit for good family medical care. What we do is very cost effective. Most of the decisions we make really don't need the red tape or the third party before we can make a decision. They just need a doctor-patient conversation. And really, when you factor in all the costs that employees are having to pay, it's just really painful. And again, they're hardly getting even the care that they want. Mostly what they're getting is coverage that they never touch. Well, again, back to what we do. Direct primary care is really a model that says, how can we make this simple? Some people compare it to like a gym model. Okay, so you pay a monthly access for your gym. When you go in, do they give you a charge for using that machine or this machine? No, oftentimes they'll throw in a tanning booth, right? We don't do any tanning booths. Just want to clear that up. But we do try and do as much as possible with our care. So we do long visits. We do 45-minute physicals. We offer after hours and weekends care when it's appropriate. We text and call and receive those calls with our patients. We do procedures, and we just ask people to help us cover the cost of the things that we throw away with that procedure, which is $30. So if you need something taken off, or you want a skin removal, or we need a biopsy, $30. We do spirometry, we do EKGs, we do all sorts of things. It's marvelous because we don't need to charge those things up that actually turn out to be very cost effective to us, or almost no cost at all. One of the other ways that we see a growing opportunity and responsibility is just by helping people navigate the medical world and make wise decisions. So where DPC tends to factor into health plans is just not a gatekeeper idea, like we're keeping people from going someplace, but good advice from a doctor that knows you and is accessible and available and can steer you towards, should I go to the ER? No, come to me. We got you. Oh yes, go to the ER. We do both of that, but what a great thing to go with that confidence and know that the ER was the right choice at that right moment. This is from Hint Health. Hint Health is one of the biggest financial membership management software that's out there right now. And they have wonderful growing evidence of how effectively DPCs are affecting the medical marketplace and reducing the overall cost. And that data is marvelous. It just keeps compounding on it. There are some large companies out there and that are realizing that every year that they have an in-house clinic very similar to DPC, that it really reduces their costs, and then their overall self-insurance costs reduces because they're not using big catastrophic care all the time by going to the emergency room for ear infections and things that shouldn't be. And when employers add a DPC to their plan, it gets used. 85%. Like, that's amazing for a benefit. A lot of benefits get thrown around in the benefit world, and so many of them just never quite make it to that level. But something that's universally beneficial to almost every employee and their family, that's an amazing thing. So we think actually a really ideal combination is to use DPC, which is interesting to think about. So in our community, again, we have several DPCs, Dr. Jones, Dr. Bouchard. I also consider the SEL, I see Dr. Gautreau is here. They have an in-house DPC style clinic. I think that's a growing model. But whether it's something that you bring in-house or whether it's something that you network with someone who's working hard, free market, I think this is a great combination to put along with something. And then use, if it is insurance or some other catastrophic coverage, use it for what it's really like, a parachute. Hopefully, if you're into parachuting or if you have a parachute, you try not to use it. That's really what insurance is for, right? Most of insurance, as we think about it, is, man, I hope that fire insurance doesn't get used. Or if you're weird, you're thinking, yeah, let's use it. Okay, then you need to have a talk with me. We need to maybe make sure. Even auto insurance, most of us are hoping our collision insurance never gets used because we know that only increases our costs. Health insurance really should be the same way. Like, let's hope and save that for that 1 out of 5 bad years. And then the other 4, let's make sure that we're saving and using that finances in much better ways. So this is us. Actually, it turns out to be less than $100. $81 is what we charge for most of our employees. We make it really easy on our employers to manage these accounts so that the red tape is almost minimal. They have a portal. We let them add members. We let them take off members. We don't require them to stay any length of time because we know that, if you have an employee that shouldn't be there, it's not great to keep paying for a benefit. But on the opposite side, if you add an employee, you want to get them on, you want to get them care, because a healthy employee or an employee that has access to real care is one that's going to get back to working much faster than if they have to wait 2 weeks or several months just to get the care that they needed. And our pledge is really to make it affordable because we're families. That's it. We're living in the same community, and we know what it costs, and we know what it costs to do all the other things that it takes to put families together. I've got 9 kids. Yeah, a lot. That's been expensive. Not all of them are married yet. We want to make it easier for the employees. We want to commit to timeliness and cheerfulness. And then we really want this to be a real benefit, something that's actually not something that would keep you from getting care you need by having a big deductible, but something you can actually use. And we're local. That's really unusual in medicine. That was the way it was for forever, until just about 20 years ago when most everything got bought up. And as it's gotten bought up, it's been a lot of the decision making for what kind of care is here in our town. A lot of the financing for what is here in our town is going elsewhere. And this is one small way of saying, no, let's invest in this. Whether it's my clinic or some of the other DPCs, please pick one and jump in and support a local doctor and keep them here so that they're not on the revolving scheme that has become so common in medicine. And we're not alone. Actually, the Family Medicine Association just came out this year, and they reversed course about 5 years ago from calling us the death of healthcare. Well, they really did. They were like, man, if every family doctor goes from 4,000 patients to 600, what's going to happen? But if every family doctor quits, we're in a lot of trouble. And about 1 out of 8 family doctors now has started a DPC in our country. That's a huge change. And it's accelerating. Mostly because they're seeing the happiness and they're seeing the medicine that they went to med school for, the same medicine I went to. I just wanted to serve people with the brains God gave me and the joy of doing it. But this is just I think this is a couple of years old. You'll notice that Cuba is not on there. No DPCs in Cuba. Yeah, socialize. You can get some interesting care there. That's the end of my slide. I really like what I get to do. And I think it's the common sentiment that I hear from DPC doctors is many of them say, wow, I was ready to quit. I left family medicine 15 years ago when I was like, I don't think I can do this anymore. And I loved my job and I loved my community, but I was never home. Being on call was a pain and painful. I knew that I was billing huge amounts to people, and that's what kind of became aware to me, much more than I thought, and it was not great. But to be able to be on the other side and to realize, okay, this is just part of a bunch of people who are thinking outside the box and saying, let's do something different, because what we're doing is not only not working well, but actually bankrupting our country. Let's make a change. Thanks so much.